We thank you all for joining our webinar tonight, and we hope that it will be an informative session for each of you. Tonight we've got Dr. Mazen Kherallah, Medical Director of Critical Care Services and Associate Professor at the University of North Dakota. And Dr. Kherallah will be discussing de-resuscitation and de-treatment in sepsis and septic shock patients. We also want to just tell you of our other panelists tonight. We've got Dr. Hawa Hassan, who is a consultant at King Faisal Hospital, which is a specialist hospital in Saudi Arabia, in Jeddah. And we've got Nabil Abushala, an associate professor at North Dakota and in pulmonary and critical care. So it's great to have panelists with such depth of knowledge tonight. I just want to let you know about everything that we're also doing with ICU Reach. So we have previous webinars and they are recorded on our ICU Reach YouTube channel. So if you go on YouTube and just type in ICU Reach, you should be able to find them there. We also have them available on our website, which is www.icureach.com. And also, please go on the website and register there, and then you will find out more of our content and you'll be able to receive emails telling you about the upcoming events. Furthermore, tonight is a webinar, but you can still ask questions and they can be placed in the Q&A section, in the chat section below, or in the comment section on YouTube, and we will be able to check the comments. At the end, there will be a brief survey, and we would like it if you could submit your feedback and your suggestions, and then we'll be able to make improvements in future sessions. There will also be a poll question, and it would be great if you could interact. So without further ado, I'm going to pass it on to Dr. Kherallah, and he can start the session tonight.
Thank you, thank you, Nabil and Hassan, for being part of this. It's going to be an interesting webinar today, as we're talking about the treatment of sepsis. We usually talk about how we resuscitate our patients and make sure that they have adequate perfusion. However, we rarely talk about how we de-resuscitate and start de-treatment for those patients. And I'm going to start with a case presentation for a patient who is 32-year-old, a female with past medical history of severe asthma, ulcerative colitis, and status post colectomy. She also is on she's on chronic immunosuppression agents. And she presented with increasing shortness of breath, cough, and fever. She was diagnosed with pneumonia and septic shock and required to be intubated. She had multiple bronchoscopies for right lower lobe atelectasis and mucus plugging. And you can see the chest X-ray in the middle. When she came to us, she was hemodynamically unstable with systolic blood pressure of 86, her heart rate of 119. And the lactic acid was 3.4. Her PF ratio was 165, creatinine 1.6, and platelets of 120. And of course, she was started on IV antibiotics as per ATS guidelines with ceftriaxone and azithromycin. And we felt that we should add vancomycin for her. Her procalcitonin was elevated at 3.87. She was resuscitated in the emergency room with 30 ml per kg IV bolus as per the surviving sepsis guideline or campaign. And she continued to have intermittent boluses with followed by IV fluid maintenance. For the blood pressure, she was started on norepinephrine that was escalated very rapidly, 2.5, and she later, the vancomycin was added later. Because of increasing vasopressor support, she was started on hydrocortisone 50 milligrams every 6 hours. And she was also on chronic steroids, so she needed the support with the stress dose hydrocortisone. She did better 4 days later The culture showed no organisms. The MRSA screen was negative. Vancomycin was stopped, and ceftriaxone and azithromycin were on. The procalcitonin was 0.7, so down from 3.87 to 0.7. The fluid balance by 4 days was positive for a total of 8.7 liters since admission. Her intra-abdominal pressure was 15 centimeter of water. Her IVC was 2.3 centimeter, and she had 50% pulsatility in portal vein on the ultrasound. Lactic acid improved down to 1.7. Norepinephrine was weaned down to 0.12 microgram per kg per minute, and the vasopressin was continued. And she remained on steroid therapy. So at this point, what would your approach would be? You start diuresis and aim for negative fluid balance. You wean norepinephrine first before stopping vasopressin, and this is you can check all what apply. You can stop antibiotics once procalcitonin is down by 80%, and you discontinue hydrocortisone without tapering once off the vasopressors. So let's launch the poll and see what kind of responses we have. Again, you can check as many answers as you want. Whatever you think is appropriate to do. Okay, let's end the poll and present the results. Okay, so you can see that we have different answers actually. Only 37% of you felt that diuresis should be given to the patient. 50% would wean norepinephrine first before stopping vasopressin. 26% would stop antibiotics based on the procalcitonin level that is down by 80%, and only 21% would discontinue the hydrocortisone without tapering. So, so the questions that we're going to try to answer would be, number one, when should we start fluid de-resuscitation? Number two, how should vasopressors be discontinued? Number three, should we taper or discontinue steroids? And number four, can we guide antibiotic discontinuation based on procalcitonin? And based on the definition of sepsis, sepsis is a systematic disease that may be associated with capillary leak, and traditionally has been treated with large volume fluid resuscitation. This may lead to fluid accumulation in the body. And the question that we're going to try to answer here, is there any association between positive fluid balance, fluid overload, and the outcome in critically ill patients? And do interventions aimed at reducing fluid balance would lead to improved outcome? As you see, based on the surviving sepsis guidelines, they recommend aggressive fluid resuscitation for patients with hypotension or lactic acid more than 4 millimole per liter. And they recommend 30 ml per kg. Unfortunately, they do not specify, do they go with the ideal body weight, total body weight, or predicted body weight. So imagine a patient with 200 kilos. If you're going to go with 30 ml per kg based on the total body weight, this patient is going to be having more than 6 liters. Anyhow, it would be better if we guide fluid therapy based on our Frank-Starling curve. And we would like to give fluid to those patients who are fluid responsive. But how many of you would do this in ER when the patient comes? How many of you would decide about the initial bolus to be given to the patient based on fluid responsiveness? I think it's very few of us would do this actually. Most of those patients are actually already have gotten the 30 ml per kg on the floor or in emergency room before they even got to us to the ICU. And interestingly, that 50% of hemodynamically unstable patients are fluid responders. And the reason being because septic ventricles would have flattened Frank-Starling curve. The curve would be shifted downwards and to the right. And those patients would show limited response to fluid loading. Not only that, after giving the bolus of fluid, in a study that included 20 critically ill patients who were given 500 ml of IV bolus, yes, we improved hemodynamics within 30 minutes, but most of those patients, as you see, within 60 to 90 minutes, they return back to their baseline hemodynamic status. And the third thing is that those patients who were initially fluid responsive may not stay as fluid responsive within a few hours in the intensive care unit. So you can see here within the first 1 hour, we had 57% of patients with septic shock who were fluid responsive. And within 2 hours, this percentage went down to 20%. And in a study that compared patients with sepsis and septic shock and no septic shock, and they were given fluid boluses, you can see that the intrathoracic blood volume increased in those patients who were not septic. However, in patients with septic shock, the intrathoracic blood volume did not go up. In the study, it showed that those patients with endothelial injury and capillary leak, less than 5% of fluid bolus would remain intravascularly after 90 minutes. What does that mean? It means that we're going to have tissue edema. Those patients will end up with severe tissue edema. And that will impair oxygen and metabolite diffusion, which also will lead to distortion of tissue architecture. And of course, this will impede capillary blood flow and lymphatic drainage. It will disturb cell-to-cell interactions. And that will lead to what we call fluid accumulation syndrome. This syndrome is characterized by increased edema, and the impact would be on all organs of the body, but mainly the encapsulated organs such as the kidneys, the liver, and the brain. In the kidneys, we're going to have increased interstitial edema, increased venous pressure that will impede the renal blood flow and will increase interstitial pressure, will lead to decreased GFR and renal compartment syndrome. In the liver, there's increased hepatic congestion, impaired synthetic functions, increased cholestasis, decreased cytochrome activity, and hepatic compartment syndrome. In the brain, we're going to have cerebral edema, impaired cognition, increased rate of delirium, increased intracranial pressure, cerebral perfusion pressure is going to be decreased, and we'll have intracranial compartment syndrome and ocular compartment syndrome. We're going to have also dysfunction of different organs in the body. The gastrointestinal with increased ascites, edema, malabsorption, increased intra-abdominal pressure, increased intestinal permeability, and increased bacterial translocation. Cardiac function is going to be impaired because of myocardial edema. Conduction system may be impaired, impaired contractility. Diastolic function is going to be impaired. CVP is going to be increased, and venous return will be decreased. Cardiac output will be decreased. In the respiratory system, we're going to have increased rate of pulmonary edema, pleural effusion, alteration gas exchange, and increased extravascular lung water. And the abdominal wall will have increased tissue edema, impaired lymphatic drainage, poor wound healing, increased wound infection, and decreased abdominal compliance. There are two definitions also that may actually encounter the fluid accumulation syndrome that are important to know. The first one is global increased permeability syndrome, which is actually high capillary leak syndrome, defined based on the capillary leak index, which is expressed as a ratio of CRP over albumin. If it is more than 60, it may be correlating with this syndrome. And of course, you're going to see excess interstitial fluid and persistent high extravascular lung water index, and your management with the late conservative fluid management strategy would not be possible, and patients would be progressing into organ failure. If you have two or more anatomical compartments that have elevated pressures, that's what we call polycompartment syndrome. Could be the head, chest, abdomen, or extremities. And the data shows, this is retrospective data, that those patients who have fluid accumulation syndrome have worse outcome. In this study that was published in 2009 in the chest, it shows that if the patient received adequate initial fluid resuscitation and conservative post-resuscitation fluid management, would have better outcome compared to if the post-resuscitation fluid management was liberal, or if they had inadequate initial fluid resuscitation, or if they had both inadequate fluid resuscitation and liberal post-resuscitation fluid. Same thing was actually also shown in another study in 2012, that early adequate fluid management and late conservative management is associated with better outcome. But those studies are observational studies. This takes us to a new concept that we need to approach our fluids in the ICU, which is similar to the way we approach our antibiotics, fluid stewardship. And we have three domains under fluid stewardship. The first one, what is the indication? Are we using the fluid for resuscitation, maintenance, replacement, or nutrition? Where are we in terms of the four phases in the Rose model? And I will explain that in details. Are we in resuscitation phase, optimization phase, stabilization, or evacuation phase? And we look at the fluid as a drug now that has an indication, it has a dose, duration, and we should de-escalate. And we have four questions to answer. When to start fluid therapy, when to stop fluid therapy, when to start fluid removal, and when to stop fluid removal. So the 4Ds would be, the four indications would be, number one, fluid challenge, which is given small dose of fluid, 250 within 10 minutes, just to assess the response, the physiological response of the hemodynamics. Versus fluid boluses, which would be 500 to 1 liter to be given to the patient over like 15 minutes, half an hour. And the purpose of this is to increase intravascular volume. Other indications for fluid would be for maintenance or fluid replacement for fluid loss like diarrhea or diuresis, or it could be also for parenteral nutrition such as TPN, or to be given with medications. In terms of the 4Ds, the way we look at fluids, like it is a drug. Fluids are drugs that have appropriate and inappropriate indications. We look at the type of fluid. In the last, I think the one before the last webinar, we discussed whether we should give our patients normal saline versus LR. And it has to be given at the right time. The fluid would have dosing and it would have pharmacokinetics and pharmacodynamics, and fluids have toxicity. And of course, there's an appropriate duration to give those fluids, and we're going to see that in details, and we treat for the response. And then we de-escalate based on the late conservative fluid management strategy or late goal fluid removal strategy. And the Rose model would take you between in phases from resuscitation, which is the early adequate fluid management. This is what the Surviving Sepsis campaign would advise, that to be aggressive in fluid resuscitation in the early phase of resuscitation. This phase would be followed by optimization. And the optimization goal would be to establish perfusion and organ rescue. And this would be based on whether the patient is responsive to fluid or not. And of course, the aim is to have neutral balance. The third phase would be stabilization, and this is late conservative fluid management aimed for perfusion and organ support. And the goal is to achieve 2 consecutive negative balance within the first week after initial insult. And the last phase would be the de-resuscitation or evacuation phase. And the goal here would be to resolve any fluid overload and provide organ recovery and removal of excess fluid. And that can be depicted on this graph here. On the left, you have volume status. And this is the y-axis. The x-axis, you have the time. So within the first hour or so, you're going to resuscitate the patient. And this is what we call escalation. And this is the resuscitation phase. And the fluid strategy is early adequate fluid management. And what you have in this phase is initial insult, hyperperfusion insult on the organs. And of course, the blood supply to the organs would be in the ABE phase. Within the first few hours after that, you need to de-escalate. This is the optimization. Perfusion is restored. You have of reperfusion ischemia on the organs, and the management of the fluid would be with the late conservative fluid management. And then you enter the stabilization phase, and you can see how we lost some fluid here. So that is negative balance. We de-escalated in the optimization, so you can see the fluid status is the same. And then we started removing, aiming for 2 negative balances within the first few days after that. And this would be followed by de-resuscitation, when we start actively removing fluid. So this is what we call late goal fluid removal. And this would be within days to weeks after the initial insult. And of course, the risk of global increased permeability syndrome is within this phase here. And if you over-diurese the patient, you may cause hyperperfusion again, and you have risk of having insult to the tissue again. So you want to avoid that. And the 4 questions that we need to ask would be when to start fluid, when to stop fluid, when to remove fluid, and then when to stop removal. And of course, there are different indicators. And this very busy slide, you can actually review it, but it includes all the parameters that we use in the ICU to guide us in terms of whether the patient is fluid responsive or not, whether the patient has fluid overload or not. And I'm going to just put this in a single slide here for you to understand. If the patient's blood pressure is decreased with cardiac index that is decreased and the lactic acid is increased, you can use any of this method here or a combination of methods to decide whether your patient needs fluid or not. And once you resuscitate the patient and the patient is beyond the optimization and stabilization phase, and the blood pressure is above, the mean arterial pressure is above 65, cardiac index is above 2.5, the lactic acid is below 3, and you have negative passive leg raising test, you can use any of these parameters here to say my patient is fluid overloaded. But I also put it for you here in this diagram here, where you have triggers for de-resuscitation, and that is based on clinical signs. If the patient's weight is increased, and the patient has positive fluid balance, and he has delirium, that may indicate that the patient is fluid overloaded. If this is combined with hemodilution in the intravascular compartment, or if you have capillary leak index above 60, it may indicate that the patient is fluid overloaded. You add to that radiological signs. Take the ultrasound and look for the B-lines. Look for pleural effusion. What is the inferior vena cava? Is it collapsible or not? And you can actually look at whether you have a high-grade VEX score or not. And we can talk about that briefly. And then you can, whatever technology you have in your ICU, you can use it to assess the cardiopulmonary function. You can assess for absence of fluid responsiveness, increased filling pressures, and volumetric preload, or if you have low pulse pressure variation in the stroke volume or in the pulse pressure. And then you look at the organs. If you have intra-abdominal pressure that is more than 12 to 15 millimeter mercury, if you have increased bilirubin, increased creatinine, all this would indicate that you may need to start de-resuscitation. And the VEX score actually is something that started a few years ago by understanding more what happens on the venous side. And you see this on a lot on social media. There are no good studies yet to look at whether this is going to be associated with good outcome, if you do it or not, patient-centered outcome. However, I started learning this actually. It's easy to learn in the ICU, and you get a lot of information. And the VEX score would go into 4 steps. The first step is you look at the IVC diameter. If it is above 2 centimeters, you proceed to the following steps. And you look at the hepatic vein, you look at the portal vein, and you look at the renal vein. In the hepatic vein, you would need to see the reflection of the right-sided pressures on the hepatic vein, with the systole, with the S wave, which is usually higher or bigger than the diastolic wave here. If you started seeing that the systolic wave is less than the diastolic wave, at that time, you have mild congestion. And this is going to be severely abnormal if it is reversed. In the portal vein, usually you see a very low pulsatility, and this is normal. If you started seeing more than 30, less than 50% pulsatility, this is abnormal. It may indicate that you have congestion. And when it becomes severe, more than 50% pulsatility, it indicates that the congestion is much more severe. If you combine this with the renal vein Doppler, you get more information. Usually you should have the continuous monophasic flow like this. If you started seeing discontinuous biphasic flow, it indicates mild abnormal congestion. And if you start seeing the discontinuous monophasic, only the diastolic phase, you don't see the systolic wave, at that time, this is severely abnormal. And of course, here you can actually divide, scale this into grade 1, grade 2, and grade 3, depending on what combination of abnormalities you have. Give you some examples here. This is the normal hepatic vein Doppler. You can see the A wave, the S wave here. This is the A wave. This is the S wave, and this is the D wave. You can see the S is bigger or higher than the D wave. And what you see with abnormalities, this is normal. S wave is higher than the D. You can see here the S wave is lower than the D. And then when it is reversed, it indicates severe problem. If you go to the portal vein, normally you see a little bit of pulsatility. If you started seeing higher pulsatility, look at this. The pulsatility index here is close to 40, 50%. And in this patient here is more than 50%. This indicates severe abnormality with venous congestion. And if you look at the renal veins, usually you should see, and this is arterial, this is renal here, the bottom one actually below the 0, you can see a little bit of variation. When you start seeing the discontinuous biphasic flow, this is systolic and this is diastolic, this indicates mild congestion. And when you lose the systolic and have the discontinuous monophasic flow, this is severe congestion. As I said, this is very easy to learn. Actually, I started learning this after the congestion cascade lecture that was given by our colleague from Baylor University, and it's recorded. Actually, you can look at it. Very nice, Dr. Murad Sunusi. So actually, he expanded beyond the VEXAS score, and he went to cover the whole system, starting from the aortic valve to the LV to the LA, including the pulmonary veins, and then going through the lungs, going to the right side of the heart, the RV, the L, the RA, and then going to the IVC, which is the VEXAS, the IVC, the hepatic vein, the portal vein, and the intrarenal vein. So if you missed that webinar, you can actually go back and watch it on our YouTube channel. But of course, this is all theoretical. What is the data? What does the data tell us? So I actually put all the studies that, and this is not everything available, but I put the most remarkable studies for you on this diagram here, the same one that we talked about. What is actually available to support the resuscitation? Early goal-directed therapy, we're going to be talking about it, and then I go with the feast and the bundle, different studies that look at the bundle, and then the clovers. Those are all in the escalation phase. We only have the classic study in the de-escalation phase that goes actually a little bit in the escalation phase, but goes beyond the escalation phase. And then we have few studies in the resuscitation. The fact that you see different colors indicates different results. So actually, there's no single study that is actually replicated in a way that you get the same results. And we're going to summarize that all. Starting with the early goal-directed therapy by Rivers from Henry Ford Hospital in Detroit that showed if you give those patients aggressive fluid guided by specific parameters, mortality rate is better. However, when we had the three studies later, I think 15 years later, the Process, Promise, and Arise studies, and compared early goal-directed therapy with usual care, there was no difference in mortality. However, when you dissect into those studies and you look at the initial fluid that those patients received prior to randomization, you can see that in the three studies, whether the patient went into intervention arm or in the control arm, those patients received around 30 ml per kg. What does that mean? It means that the early goal-directed therapy evolved into usual care. And if you give those patients fluid, the outcome is going to be the same. And this is actually shown in the pilot study for the Clovers protocol, where they looked at the difference in the fluid given to the patient. And you can see the reverse study here, where the difference between the intervention and the control was high. When the difference is high, you got higher survival rate. When you resuscitate the patient with fluid, you get a better survival rate. However, in the Process, Arise, and Promise, those patients received enough fluid on both arms. And that's why we did not see a difference in mortality. All right, so the early goal-directed therapy indicated that in the resuscitative phase, giving those patients adequate fluid would be beneficial. Okay, so if we go to the FEAST study, and the FEAST study is a unique study that was done in children in Africa, but it was also replicated in Tanzania in adults. For those patients, they were divided actually into three groups. One group got albumin bolus, another one got saline bolus, and the third one got no fluid bolus at all. They ended up, of course, you're going to give medications, patients going to get some fluid. They ended up having an average 40 ml per kg in the albumin and in the saline bolus group. But in the no bolus, they only had 10 ml per kg. So it is much less than the 30 ml per kg as usual bolus for those patients. And look at the mortality, it was better. So no fluid indicated better mortality, and you can see that in the Kaplan-Meier curve. This is the no boluses, has a better survival compared to the other two groups. So in fact, here it's in red because, well, now if you give fluid, it's not good. All right, let's look at the study that looked at the bundles. So the bundle, which is the 3-hour bundle that we give, it's actually recommended by the Surviving Sepsis campaign. And this study is in New York State, and it's by the Department of Health, included 50,000 patients, and those patients were in 150 different hospitals, where they looked at the outcome in relation to, number one, the time to completion of the 3-hour bundle. And that 3-hour bundle included cultures, blood cultures, broad spectrum antibiotics, and lactate measurements. And it showed that a delay in achieving these 3 components would be associated with increased in-hospital mortality. Same thing for the initiation of antibiotics alone. If you delay initiation of antibiotics, you're going to increase in-hospital mortality. However, we did not have the same thing with the fluid bolus. With a delay in the fluid bolus, you see that the in-hospital mortality is the same. So that actually tells us that it may not actually be very important to give fluids. So it's in orange here because, well, it's in between. We did not see worse outcome. We did not see better outcome. So it had to be another study that will look into this. And the CLOVER study, we were hoping that actually, if we don't give those patients fluid, at least they would have the same outcome or better outcome. And the CLOVER trial that was published this year in New England Journal of Medicine, they randomized patients into restrictive strategy where they had to give fluid only for certain indications. And they concentrated on giving vasopressors mainly, compared to liberal strategy where they gave fluid as per Surviving Sepsis guideline and less emphasis on vasopressors. Well, they ended up, those patients, and by the way, those patients prior to randomization, they got like on average 1 liter of fluid. So it was less than what it's recommended by Surviving Sepsis campaign. But they ended up having on average within the first 24 hours, the median fluid was around 1.2 liters. On the other side was 3.4 liters. Mortality within 90 days is not different, whether they were having fluid or not having fluid. So it's neutral results actually. It really doesn't matter much if you are aggressive in fluids. You need to maintain some perfusion, but you do not need to be aggressive in your fluid management during escalation phase. Now, moving to optimization and stabilization, we have the classic study that also looked at around 1,500 patients altogether and was randomized into restrictive fluid strategy where fluid was given for hypoperfusion state, well defined in the protocol. And compared to standard fluid, this is as per Surviving Sepsis campaign. Those patients received at least 1 liter of fluid. I think the CLOVER study received 1 to 3 liters prior to randomization, and in the classic study received at least 1 liter. You can see here, 90-day mortality is not different. And those patients in the standard fluid received more fluid than in patients with restrictive fluid, but the outcome is the same. So we don't have any preference in terms of the strategy. Now, moving into de-resuscitation, what evidence do we have? We know that the FACT study from, I think, 2006, we know those patients with ARDS, when they are stabilized, if they are diuresed, and if they are diuresed aggressively, and you can see here in the conservative fluid, we had a 7-day fluid balance in the negative. In the liberal group, we have a 7-day fluid balance around 7 liters. Well, if we do this, we're going to improve length of stay on the ventilator. Those patients were extubated earlier. However, 60-day mortality was not different. And this is now a practice in the ICU for those ARDS patients. We try to keep them dry after stabilization in order to liberate them from the ventilator easier. Okay, so we have another meta-analysis, and the meta-analysis goes back, I think, 2016 or something. And this meta-analysis shows that the mortality rate in liberal fluid therapy is higher than in restrictive fluid therapy. But if you look at this meta-analysis, it included so many studies, observational studies, randomized control studies, and even case series. And the mortality is better with restrictive fluid. However, look at the heterogeneity, it's very high. I don't think we can actually infer much out of this study. So we needed a well-designed randomized control trial. And I'll talk about the GODEF, but before that, there's another meta-analysis. And that meta-analysis included only the randomized control trials. And in this meta-analysis, you can see that there's no difference between the de-resuscitation, active de-resuscitation, or usual care in terms of mortality. And you can see that the number of patients here is very low, relatively speaking, and there are 5 studies altogether, and there's no difference in terms of mortality. So we had to have a well-designed randomized control trial, and here we have the GODEF trial. The GODEF trial, actually, unfortunately, it was well designed. However, it had to be stopped early because the imprecise fluid balance assessment. In their assessment, in the first edition, in the first version of the study, they designed the study in a way that they look at the fluid balance over the days to decide whether you're going to give patient diuresis or not, or to randomize patients, whether the patient goes into the diuresis arm versus the control arm. But it was very difficult, actually, for this fluid assessment to be utilized for this randomization. They decided to stop the study on January, or the study was published in January 12, 2023, with the results of 40 patients only. So based on that, we say that the current evidence for de-resuscitation is limited by, number one, the lack of high quality randomized control trials, the small sample sizes of the studies available, the heterogeneity of patients population, and the heterogeneity of the applied de-resuscitation technique that we use. And in practice, and this is what I do in my own practice, well, the studies do not, the evidence do not support how we're going to be, how we're going to do the fluid resuscitation, de-resuscitation in the ICU. But let me summarize this for you in this diagram here, which I think it's very reasonable approach for fluid administration is to limit fluid administration to patients with objective markers of, number one, hypoperfusion, and hypoperfusion combined with fluid responsiveness. So you use whatever method you want in your ICU to assess whether if I give my patient fluid, will he respond? So if the patient is fluid responsive and has hypoperfusion, at that time, you give fluid to this patient. Then you start de-escalating for organ rescue and support. And this is the second and the third phase, the optimization and stabilization. You look at the tissue perfusion. You should have adequate tissue perfusion or objective measures of no responsiveness. So you do not give fluid if the patient is not responding to fluid. If you have adequate tissue perfusion, you do not give fluid. So here where you de-escalate, you stop giving fluid. You don't need to give any further fluid. Then you decide about de-resuscitation in the following phase. And this should be based on organ dysfunction. If you have organ dysfunction and fluid overload, together you start de-resuscitation. Or if you have only fluid overload without organ dysfunction, you also start the resuscitating. And ways to do this, actually, I'm not going to talk about that in details, but you have different approaches for this. Combination therapy with diuretics. You can apply PEEP, you can use albumin followed by diuretics, and you can use PAL treatment, which is PEEP equal to intra-abdominal pressure plus albumin 20% followed by Lasix. Or you can use the different ultrafiltration methods available on CRRT. So the next question is, how should vasopressors be discontinued? In the study, whether we should stop actually first vasopressin or we should stop norepinephrine. And the majority of you answered that we stop first the vasopressin, followed by the norepinephrine. In fact, this study and the studies available for this are all retrospective studies. In this study that included around 90 patients in each arm, looked at whether we stop the vasopressin first or last. And look at what happened. If you stop the vasopressin first, the rate of hypotension was close to 70% compared to stopping the norepinephrine first, followed by the vasopressin. And this is also supported by two other retrospective analyses that show the same results. And we don't have any randomized control trials, but based on those retrospective analysis, you can probably consider stopping first your norepinephrine or weaning off norepinephrine before stopping vasopressin. And the third question, should we taper or discontinue steroids? And the answer to this, the best answer would be from the study that looked at the patient-level meta-analysis published in the New England Journal of Medicine this year, evidence this year, and looked at those patients who had where the steroids were tapered compared to no taper. And you can see that there's no difference in mortality. And what we do in our ICU, we just stop the steroids without, and that steroid that is used at the stress dose at 50 milligrams every 6 hours, we just stop this after stopping all the vasopressors for the patient. And the last question, should we guide antibiotic discontinuation based on the procalcitonin? And the PRO-RATA trial that actually looked at this issue, they stopped the antibiotics if the concentration of the procalcitonin reaches less than 0.25 or 80% from the peak. And what they found that the days without antibiotics were much higher in the procalcitonin group compared to the control group. So you can actually stop antibiotics earlier. And there was no difference in the 28-day mortality or the 60-day mortality. Same thing in the Belgium study. This is a randomized controlled open label trial, included around 1,500 patients. Those patients whom they used the procalcitonin to stop antibiotic therapy had lower antibiotic daily defined dosages. They used less antibiotics, and duration of antibiotics was lower compared to the control group. At the same time, they found that the mortality was better for those patients that they used procalcitonin to guide stopping antibiotics. And the meta-analysis that was published by in the Critical Care Medicine Journal looked at multiple studies here put together, and those are comparing the procalcitonin as a guide to stop antibiotics compared with control. And they found that if you use this method, it will be associated with less duration of antibiotics, but there's no difference in mortality when they put all the studies together. And the recommendation of the Surviving Sepsis Guideline or the Surviving Sepsis Campaign is to suggest using procalcitonin and clinical evaluation to decide when to discontinue antibiotics. So with this, let's put the question again. And based on what we just learned, how would your approach be for this patient? You need to relaunch Grace again. Yeah. Okay. So would you start diuresis and aim for negative fluid balance? Would you wean norepinephrine before stopping vasopressin? Would you stop antibiotics once procalcitonin is down by 80%? And would you discontinue hydrocortisone without tapering? Okay, let's end or share the results. Perfect. So you can see that we have improved. We were in the 30 to 40 range. Now we have 63, the minimum, up to 75. And in fact, actually, the answer is that you can do all of those interventions. You can start diuresis for this patient. This patient, her intra-abdominal pressure was 15, and she had signs of venous congestion, and her hemodynamic profile was improving. We can wean norepinephrine first before stopping vasopressin to avoid rebound hypotension. Vasopressin half-life is longer than norepinephrine, so you can stop it the last. And then you can stop antibiotics because her procalcitonin reaches a level of 80% of the peak. And it's day number 4. If you want to complete 5 days as per ATS guidelines, that would be fine. You can discontinue hydrocortisone without tapering. There's no need to taper the hydrocortisone. You just stop it right away and monitor the patient. Your patient is still in the ICU. If he becomes hypotensive, you can manage. Take-home message would be know when to give, when to stop, and when to remove fluid. Again, I would guide this based on 2 factors. Number 1, the perfusion status of the organs, and number 2, the fluid responsiveness results of the different techniques that you may have available in your ICU. Number 2, consider discontinuation of norepinephrine first, meaning that weaning norepinephrine first, and then there's no need for steroid taper. You can just stop it, and you may use procalcitonin as a biomarker for antibiotic discontinuation. Thank you.
Okay, so we'll move on. If anyone has any questions, feel free now to add them to the chat. You can do it on the chat function at the bottom, or if you're listening on YouTube, you can also add it to the question, to the comment section on the YouTube video, and we'll have a wee check of both.
Can I?
Perfect. You can comment or.
Well, thank you very much, Mazen. Really great talk, mashallah. I really must congratulate you on the slide that you put. I think there is you have put a lot of thought behind the slide of when to give fluids and when to start the resuscitation. If you could please put it back, because I loved it. One thing to mention while you are putting the slide back, Mazen, really the best thing as ICU doctor you can do, if you can, is to catch your patient at the early phase before they spiral down into the sepsis cascade and getting into the multi-organ failure state, when no matter what you do, they will be leaking fluids all over. And yeah, that's the slide, Mazen. I really must congratulate on it. I mean, I recommend everyone to have a thorough look at this slide, and I would totally agree with using it in daily practice. Definitely a lot of thoughts went behind writing this slide. Amazing, Mazen, well done. So I was saying about the importance of catching your patient early before they cascade down to capillary leak syndrome. The notion of giving 30 ml per kg the Surviving Sepsis campaign put it at some point at with the 1 hour bundle, but later on they said, oh, probably it has to be over 6 hours. And I think even 6 hours, probably that's too much. So the best thing you can do, and I would like to hear from my colleagues, Mazen and Nabil, is really individualize your approach to your patients rather than just go blindly and give the 30 ml per kg over a few hours or so. If your patient is not responding to fluids, as Dr. Mazen suggested here, then probably you shouldn't be carrying on giving them fluids anyway, and you have to change gear and change your approach to these patients by focusing more on using the vasopressors and inotropes to support the circulation. What do you think, Dr. Nabil and Mazen? So individualize your approach.
Yes, I fully agree with everything you said, and want to thank Mazen for these great slides. And I think putting them together is not easy, given the multitude of studies. So I think the outline and that graph for the first several phases is make it really much more understandable. Now, I think it's one of the common things we all at fault is, do we really do this dynamic fluid assessment all the time? And it is time consuming. If you're going to take the ultrasound and you don't use it very often, you're going to feel uncomfortable. It's going to take longer time. And if you are in a rush and have large number of patients, that's not going to get done. So I think making it a habit, doing this routinely is part of the physical exam. And then particularly if you start knowing that patient, yesterday this patient did not have B lines, or he had 2-3 B lines, so he has more. So this continuous assessment, making it part of the routine physical exam on patient would help to identify who is fluid responsive today, who is not, and should I give fluid, instead of empirically doing this. Not all the time. We do have sometimes patients that are already hooked up with arterial line and we can do the stroke volume variation, but so sort of, doing this, if you do it every day and you get used to it, it becomes part of the routine. And I think we would, appropriately give patients fluid. So that's, I think, that the first phase, and making it routine in the assessment. And I think and the interesting part, and that's something we always have issues later when the patient develop renal failure and nephrologists say, don't give Lasix. And we tell them, the studies have shown if you de-resuscitate, remove fluid, the kidney function gets better. These are swollen kidneys rather than, so you've seen that notion many times, no Lasix and renal failure. That's here we see that the aggressive fluid resuscitation leads to more chances of developing renal failure, multi-organ failure.
Yeah, thank you very much. I agree with both of you, actually. I just put a blog post on ICU Reach, and the summary of that is that one size does not fit all. I think you need to individualize your care to your patient, and the two parameters, hypoperfusion and fluid responsiveness. So they need to be together in the resuscitation phase to decide to give fluid. In the de-escalation, any one of them, if you do not have fluid responsiveness, you don't need to give fluid. Adequate perfusion, you don't need to give fluid. And in the de-resuscitation, you have organ dysfunction and evidence of fluid overload or fluid overload. Now, with the ultrasound, I agree with you, Nabil, it's time consuming. However, what I noticed that I'm getting better. I started doing the congestion cascade as Dr. Sanusi suggested, and it was so difficult in the first couple of ultrasounds. We just did that last week on one of our patients. It took me only 5 minutes altogether. It was so easy. Of course, getting a good window will help. Sometimes if you don't get those windows, it's very difficult to make that assessment, actually. You're lucky if you have someone who's skinny, where you can see the veins very easily, and then you can make the suggestions. I think there's a learning curve with this. It gets better as we do more ultrasounds. And I'm not wasting much time in the detailed physical examination as much as I do it with the ultrasound now.
Yeah, I must say, thank you, Mazen. One more thing, really we have to pay attention to the hypoperfusion markers. And if your patients is not showing markers of hypoperfusion, then really, even if they were fluid responsive, you need to just slow down on fluids, because if the tissues are getting the perfusion they need with the current level of volume in the circulation, then do you really need to push the volume a bit more to make it better? Or if the patient is already good at perfusing, mentating well, if he's still awake and not intubated or sedated, still passing urine, the lactate is normal, you've done the CVO2 or the CO2 gap, all these parameters are really good tools for you to judge the patient's perfusion status and decide about the fluid resuscitation. Right, I think there's a couple of questions in the chat. Yeah, sorry. Go on,
just wanted to make a comment on this, and I think, I don't know if somebody did this study recently, but from the FACTS trial, which looks at fluid balance in the patients with ARDNET, on average, if you don't do anything, your patient is going to be at least 1 liter positive every single day. So 7 days, 7 liters positive. So you look at that in the future, look at how many drips they're getting. It is very difficult for the patient to catch up and be, isovolemic or maintain good balance or an even balance without us interfering. So you either have to cut down, and you may have to give a little bit of diuretics, but on average, in patients in the ICU with too many drips and enteral feeding and flushes and so forth, they end up about 1 liter per day.
Absolutely, you're correct, Nabil. And one of the authors I've attended one of the lectures, he called it the mission creep. So you are creeping the fluids without noticing, as you said, with the antibiotics, with all the fluids, the drugs that you're giving, they are diluted in large volume of fluids, and you end up really having a patient at least 1 liter positive without even giving him the maintenance fluids or supplemental fluids. You're right.
Okay, so I think we'll go to some of the questions in the chat, unless there's anything else you want to say at the minute. The first question in the chat is from Suray Bakar. How long should we use hydrocortisone for?
Well, I usually it's 7 days actually, but I really stop hydrocortisone once the patient is hemodynamically stable and off vasopressors. If that happens within 3-4 days, I don't continue hydrocortisone.
Perfect. The second question is from Dr. Al-Wali. What is the role of empirical antibiotics in sepsis?
Well, that's actually the most important thing that you need to give your patient is antibiotics that, number one, are appropriate antibiotics, meaning that they cover the organisms involved in the sepsis. Number two, they are given early as possible. Every 1 hour delay may increase mortality between 3% to 8% based on different studies per hour. And number three, they should be adequate. The dosing, the pharmacokinetics should be studied very well, and you should give enough medication to be above the MIC of the organism and be able also to reach that organism in the specific organ that is involved. Meaning you don't give ciprofloxacin for meningitis. It's not going to get there, actually. You need to give adequate medication, such as ceftriaxone or cefotaxime, that has good penetration into the CSF to cover the organism and reach a level above the MIC of the organism. Similarly, another example, if you're treating MRSA pneumonia, or if you are suspecting MRSA pneumonia, your vancomycin level should be between 15 and 20, so you can be above the MIC of that organism inside the lung parenchyma. And I think in the slide that I showed earlier, actually, let me just go back to it. You can see the mortality rate goes up very high. If you, this one in the middle, you can see every 1 hour delay in the administration of antibiotics And that means appropriate antibiotics, adequate antibiotics. Every 1 hour delay is associated with an increase in mortality.
Perfect. Okay, so there's another question. We'll go skip to some of the YouTube questions for now. One of the repeated questions was, how is delirium associated with fluid overload?
Say that again, the question,
Sorry.
Grace.
How is delirium an
Well, yes. So that because of the increased also fluid inside the brain tissue. If you have cerebral edema, you're going to have increased rate of delirium for those patients, even if it is small amount.
Okay, so the next question is quite long, so we'll break it up into sections. So this is from Dr. Kasma, and he says that he or she is from the pediatric world, but the concepts are quite similar actually between peds and adult medicine. So firstly, what conservative fluid maintenance should we step down to 80 to 90%? I'm not quite sure what maybe they meant by the question. But they've mentioned.
Well, let's just take it into pieces. I see the question. So he's saying, well, after the resuscitative phase, that we give the fluid based on what we discussed, how we're going to do the conservative fluid management. I did not actually detail in terms of how we're going to do conservative fluid management versus late goal fluid removal. So I just briefly mentioned that conservative fluid management is to maintain neutral balance within the optimization phase and a negative balance in 2 days consecutively in the stabilization phase. And in terms of fluid maintenance, I'm trying to actually started to change my practice. I'm stopping maintenance altogether. There is no need for maintenance. And as Nabil mentioned, those patients are getting enough fluid with medications, and you're starting feeding for those patients. So I really, at the end of the optimization phase, I stop all fluid maintenance, if that answers your question. So when you say step down to 80 to 90%, I would go with the fluid balance for the patient. You really need to make sure that the patient is making urine, is getting rid of the fluid that you're giving him, and has obtained neutral balance during the optimization phase and negative balance in the stabilization phase.
Perfect. And just touching on the furosemide boluses versus titration.
Well, I usually start with the furosemide boluses, and in the literature, I'm not sure, I vaguely remember that there is a study looking at the infusion compared to boluses, and I don't remember that there's any difference in terms of the diuresis in one way or the other. Hassan or Nabil, do you know if I don't usually start their infusion of Lasix unless I try it actually if the boluses failed to cause the diuresis.
I agree, Mazen. That would be my approach too. I'll start with bolus because with infusion you are allowing yourself to safely give the Lasix at high doses without causing any harm, even though I've came across something called Lasix challenge, and people would give mega doses of Lasix boluses, but I'm not sure this is a universally agreed practice in critical care.
Yeah, I think that I'm aware of the only benefit of Lasix infusion over boluses is in cardiac surgery patients post-op for fluid removal. And I think if I have a patient that I know they're quite fluid overloaded, but they still are requiring some degree of vasopressors, then using Lasix infusion is not going to give you significant swings of blood pressure. It'll give you sort of a continuous smooth diuresis rather than big boluses of diuretics. So that might answer the question. Next is that, I mean, that would be one of the options if clearly the patient's fluid overloaded and still requiring hemodynamic support.
Okay, so the next question is, how can we start de-resuscitation when the patient is still hemodynamically unstable?
A very good question, Dr. Abdul Hamid. This is, if you attended the last webinar, Dr. Sanusi presented a case of a patient who was hemodynamically unstable. And then he de-resuscitated the patient and hemodynamic profile improved. But he started the resuscitation based on the fact that the patient is fluid overloaded. And he had a huge venous congestion indicated by the ultrasound. And if you have congestion, what will happen is your cardiac output is going to be low, stroke volume is going to be low, cardiac output is going to be low, your patient is going to be hemodynamically unstable. And then at the same time, your kidney functions are worse because of the congestion, as Dr. Nabil mentioned, congestion in the kidneys. So it is very actually critical. We're not saying that you're going to de-resuscitate a patient who's hemodynamically unstable because he needs fluid. No, we're saying de-resuscitate a patient who's fluid overloaded. And if the patient is hemodynamically unstable, it has to be secondary to fluid overload. Now, of course, there are some patients who have persistent vasodilatory effects because of, especially those patients with renal failure, patients with liver failure. You can have this low SVR syndrome, and those patients are going to be maintained on some vasopressors. Actually difficult to assess whether those patients should be de-resuscitated or not. What I do in those patients is case by case. I look at all those parameters. I may support the blood pressure with a little bit of vasopressors, but if I feel that the patient is fluid overloaded, I start the Lasix. For those patients, what I do, I give the albumin followed by the Lasix to try to mobilize those fluids from the third space.
Okay. The next question is, can we use dexamethasone or methylprednisolone in sepsis?
Well, in sepsis, what has been studied is hydrocortisone, and you may decide to add fludrocortisone to the hydrocortisone for the mineral activities. It's been debated in the literature, but I would not use dexamethasone for sepsis, except in ARDS patients. So, if the patient is in septic shock and you want to support the blood pressure, you want to wean the patient off the vasopressors, the answer is hydrocortisone. It's not dexamethasone, it is not methylprednisolone.
Oh, sorry. Back to some of the questions on YouTube. Let me have a look. If the patient is still on noradrenaline, tapered to a small dose, should we be keeping them on a steroid until noradrenaline is off?
Yes, I would keep the hydrocortisone till the norepinephrine is off, but if by day number 7, the patient would still need norepinephrine, and it is because what I mentioned is like renal impairment or patient with liver failure. I may actually use some midodrine for those patients to support blood pressure and try to stop the norepinephrine or wean off the norepinephrine, but I would stop the hydrocortisone at that time.
Okay. And a final question on YouTube. I think I'm trying to interpret this right, but is there any use of the mixed venous oxygen saturations from the management of sepsis?
Yes, and this is what the initial protocol that Dr. Rivers used. At that time, the early goal-directed therapy was defined as number 1, mean arterial pressure more than 65. Number 2, CVP above 8. Number 3, mixed venous saturation above 70%. And number 4, the hemoglobin above, hematocrit above 30. What the literature after that proved that there is no need to monitor the mixed venous saturation, and there is no need to keep the hemoglobin or the hematocrit at 30 ml. And the CVB is not very accurate, actually. So the 3 parameters of early go-directed therapy that we monitor, actually, we don't do them anymore. However, we still giving fluid to our patients who are fluid responsive and have evidence of hypoperfusion.
Okay, and one of the final questions in the chat is, can more than 3 vasopressors be used in a case of refractory septic shock?
Yes, I think Hassan can comment on that too. Hassan, go ahead, and you raise your hand.
Thank you very much. I meant to make a comment about the use of mixed venous oxygen saturation.
Go ahead.
Outside the early go-directed therapy, I might use it if it's low. That might suggest to me this is a surrogate marker of poor cardiac output. So probably my patient is suffering with septic cardiomyopathy. And at that stage, you might want to consider adding inotropes. If your patient is on high dose of norepinephrine, then probably the appropriate inotrope to use is epinephrine itself or adrenaline. However, if your patient's on a small dose of norepinephrine, then probably you can add dobutamine safely or milrinone according to your patient's status. If the venous oxygen saturation wasn't helpful, was normal or even high, then I would do the CO2 gap at that stage to make sure I'm not missing a cardiac element to this patient's hypotension. And that brings us to the patients of refractory shock. So when you have someone with refractory shock, you need to make sure that the problem is not in the pump. So you really have to have a close look at the heart by doing a cardiac echo, advanced hemodynamic monitoring if possible, and using these markers that we talked about, the venous oxygen saturation and the CO2 gap. By all means, if you have to use inotropes. You're going to introduce adrenaline or epinephrine at this stage if your patient is requiring high doses of pressors. Mind you, you have to look at the reversible or potentially reversible causes of refractory shock. Yes, we were saying now in this lecture about fluid de-resuscitation and to avoid fluids. However, if your patient is really hypovolemic, then that might be the reason he's requiring high doses of pressors, and it would be appropriate at that stage to give some volume to restore the filling pressure of the patient. Or you might want to look at the severity of acidosis. Do I need to correct the acidosis? Do I need to correct the hypocalcemia that's present? Or have I overlooked presence of adrenal insufficiency and didn't give steroids or adequate dose of steroids? All these things should be in your mind when you are tackling a patient with refractory septic shock.
I'm not sure I understand.
I have one comment on the mixed venous. I want to make sure that sometime I've seen this practice patient taking the venous sample from the peripheral arm and consider it as a venous blood gas. That is really very worthless. None of the studies, I mean, you're taking a very poor sample of the venous saturation. So make sure you're taking it from the central line, preferably from the distal tip. But that's how the study was done before. And again, is a very poor correlation. I do it when I don't have any access to ultrasound or echo, or you can't do dynamic assessment, and you just, sometimes you're putting a central line, you really don't know what's wrong with that patient, and you in the middle of the central, sometimes I draw the blood gas when I put the line and I send it and I say, just give me an idea. I want to know, is that mixed venous very low, like 40%? Do I need to worry about the heart? But to use it as a monitoring and for resuscitation is not good.
It's part of the jigsaw puzzle that we talk about always in hemodynamics. So it's one piece of the jigsaw puzzle. Doesn't give you the whole picture. Yeah, I agree with you.
Perfect. Well, that is the end of the questions tonight. I think we've gone through all of them in the chat and also on YouTube. Thank you. We really appreciate that you put the effort into asking fantastic questions. It really helps broaden out your learning. And of course, my learning too from a session, because we can explore it more together and find out what we're finding difficult. Just to let everyone know, there's going to be some survey questions now, and we would appreciate if you could answer them. And again, I just want to thank you. Thank you for coming tonight, and also a big thank you to our panelists, to Dr. Hawa, to Dr. Nabil Abushala, and to Dr. Kherallah as well. We really appreciate the time that you put in to teaching us. And finally, at the end, there's also going to be a campaign that we're going to show you. It's a support campaign, and it's called Empower Through Education. And what we're doing is raising money, and it's to be able to provide this resource for free for everyone who needs it, who maybe doesn't have the financial capability of getting to ICU Reach to pay for their own resources. So we're going to raise money for that. So if you're able to contribute in any way through the PayPal link, we would really appreciate it.
Thank you very much, everyone. Thank you, Grace. Thank you, Hassan and Nabil.
Thank you very much.